When there's a child out there that's not getting the same that your own child is getting, the difference will tell, and there will come a time in the society where that child is going to take its pound of flesh.
Where you can actually, everything from watching a program with the child, you can start off the conversation from something on the TV and say, oh, you know.
For me, it's like, hurry up with this business. And the other one said, Auntie, it's not about me, it's about the guys. They're not ready to marry.
Yes. If she wants to ask something, no, I know my mother very well. In fact, the most interesting one is when I put up pictures on WhatsApp, you know, Snapchat filters and all that, she will call me, remove that picture. There was a day I got tired of all that and I said,
Oftentimes we cringe at the mention of mental health. Truth is, it is real and abound within us. In Nigeria, an estimated 20% to 30% of our population are believed to suffer from mental disorder. This is a very significant number considering Nigeria has an estimated population of about 200 million people. Unfortunately, the attention given to mental health disorder in Nigeria is at best mentioned. The level of awareness of the Nigerian public on mental health issues is also understandably poor. Thus, the misconceptions regarding mental health continue to flourish. Mental health disorders are not easily noticed, but the burden of mental health disorder in the society is projected to reach about 15% by the year 2020. By this time, it is estimated that common mental disorder such as depression, anxiety, and substance abuse-related disorders will disable more people than complications arising from HIV/AIDS, heart diseases, accidents, and war combined. This is an astonishing statistics and poses serious questions as to why mental health disorders are not given more attention than it currently receives. The above statistics are rather very alarming, and in the light of a recent suicidal episodes recorded in parts of Lagos, particularly the Third Mainland Bridge, obviously those are just a tip of the iceberg. It forces a rethink in our general attitude to mental health. It also questions our current maintenance of the status quo. The 2016 World Health Organization aims on mental health system in Nigeria made some telling revelations. It reported that there is a considerable neglect of mental health issues in the country. Agreed, there is an existing mental health policy document in Nigeria, but it was formulated way back in 1991. Since its formulation, no revisitation, no revision has taken place. Consequently, no formal assessment of its implementation or success has been recorded.
I don't think in gender boxes at all. I just get on with it. A man that would dare to ask the wife, who do you think you are? That is a real man.
In fact, our husbands are our firstborns. The husband needs more attention than even the children. It's not only about work, it's not only about family. They need to take the time to look after themselves, and we don't. We don't do that.
They took my money. I paid every fees. I never asked to be hoisted as a governor. I wanted to be allowed to go out there and contest for the position of governorship candidate first.
There's nothing greater than looking back and seeing that while you were aspiring, you were able to inspire others.
Power to women.
Yes,
we need to have more women, more multitaskers around Nigeria to get Nigeria working.
Definitely.
We're in the conversations room today and we're talking about mental health. It's a full house today. We have Dr. Winifred, which I'll start with you. Maybe you want to tell us exactly what is mental health for people who are listening and don't understand exactly what that means.
Okay. The two different things. There's mental health and the mental illnesses.
Okay.
So talking about mental health. Mental health is a state of well-being where people are able to recognize their potential, able to cope with day-to-day stressors, able to work productively and contribute to their society.
Okay.
That's mental health. And talking about mental illnesses, right?
Yes.
So mental illnesses are a range of symptoms, mostly characterized by abnormality in emotions, thoughts, and behavior.
Okay, so what's the difference between what you do? You're a clinical psychiatrist, am I right?
I'm a psychiatrist.
You're a psychiatrist, and what she does, Dr.
I'm Dr. Shaibu.
Dr. Shaibu, is it a little bit different or is it the same?
Basically, I think what you would like to know is the difference between me and psychologist.
Yes, psychologist, thank you.
Yes. So I'm a psychiatrist.
Yes.
I'm a physician. First of all, I am a doctor.
Okay.
And I specialized in mental health.
Yeah.
So I diagnose and treat mental illnesses.
Okay.
Via the use of talk therapy and medication. So talk therapy is mostly done, evidence-based talk therapy is mostly done by the psychologist.
Okay.
Yes.
Okay. Do you want to talk a bit more about what it is that you do and how you do it?
Just like Dr. Winifred said, so for the psychologists, what we do is we use some so we call them skills or we call them assessment.
Okay.
So say for instance you have someone that come and they say, oh, I have depression. You don't just start talking to the person. So what you do is we have different kind of skills that we use to assess the level of depression the person is saying they're having.
Okay.
Now sometimes you could have severe, sometimes you could have mild. It just depends on what the skill gives you. And then from there, if the person needs medication, then you liaise with the psychiatrist. Most times what happens is the psychiatrist might have seen the person first and calling the psychologist to say, okay, I have seen this person, I'm diagnosing this person for depression or for bipolar, whatever it is. I would like her to also have psychotherapy alongside using the medication.
Okay.
So when that happens, the person then comes for therapy where we use things like CBT. So CBT is cognitive behavioral therapy, or DBT. So there's different things that you use to talk to the person. Now, it's not counseling. So there's a difference between going to be counseled than going to see a psychologist. Now, counseling, somebody's trying to see how they can talk you out. So what you do is you try to build on the person's motivations, because what the medication would have done is worked on the chemicals in the person's brain. So you are trying to build the person's motivation, talking to them. So say, for instance, someone says, oh, I have low energy, or I don't have interest in doing some of the things I want to do. You're finding out, okay, what are your interests? Why don't you try this? Why don't you do this? So those are the ways that you're trying to get the person to start doing things they actually enjoy doing before, they got depressed.
Okay. If I may come in, Dr. Shaibu, I'll throw this at you because you're both psychiatrists, right? Yeah. Typically when we hear about, I think what we're focusing more on today is actually mental illness, but the topic broadly is mental health.
Yes.
So we'll be discussing things that have to do with mental health too. Yeah. But the typical person knows a madman. Yeah, because they're half naked, they're dirty, their hair's unkempt, they're walking on the street, talking to themselves, picking food out of the garbage, and so on. When it's at that extreme, as professionals, what is that type of thing called? Because as far as for the layman, that is the only mental illness they know. And then maybe lately people talk about depression, so people know about that as well. So it's those two, depression and then the madman or madwoman on the road. So that madman on the road, what is that?
Okay. First of all, I would like, to answer the question.
Yes.
In mental health, we don't have that word MAD. As a matter of fact, I don't like to call the word. Yes, because it's stigmatizing, right? We just see people who are mentally ill, right? So just to make people understand, we say, okay, there's the physical health and there's the mental health. Okay. A lot of people can relate with the physical health. Oh, I have abdominal pain. Oh, I have diabetes. Oh, I have hypertension, right? So it's easy to say, oh, he's ill. We empathize with them. But once you say, okay, the mental health is sick, people can't relate. Yeah. Oh, I don't feel interested in doing the things I used to love to do. Oh, just snap out of it. Yeah. Let me take you out for a drink. It is an illness. The person isn't just lazy, right? The person is unable to, because there's an imbalance in the chemicals that help you do these things. Okay. So that man that you described, that picks food from the garbage, that roams the streets, and most times they're suffering from what we call schizophrenia.
Okay.
Right? And it's amazing that, you know, because of the stigma, those people actually have families, but for some reason, because of the illness, they wander away, they leave the town where people know them, and then they're just left on the street. If someone could pick that gentleman or the woman and start them on medication, it would be amazing to see how they will transform.
Yes.
Right? So you get them to a stage where they're able to gain what we call insight, and they realize, oh my goodness, what am I doing here? Then psychologist comes in. So like it's a combination kind of treatment. You do pharmacotherapy, the medication, and then the psychotherapy, which is the talk therapy, for the person to understand what is it that is happening to you. Why was I behaving that way? And what are the things I need to do to make me not go back to that state? But so because of that picture that people see, when I present to a doctor and say, okay, I feel this way, I feel that way, and the doctor says, oh, it's a mental illness, we're quick to say, oh, it's not. It's simply depression. Depression is a sort of mental illness. Anxiety, post-traumatic stress disorders, they're all mental illnesses, as long as you cross to the path where you're able to cope with activities of daily living. It affects your relationships with people, you know. So that's what Dr. Winfrey was saying. So basically, if we understand that, things that affect our mental health are mental illnesses. Things that affect us physically are physical illnesses. So we're trying to, and I'm happy this is happening, this conversation is happening, because as long as we're able to understand these things, stigma will reduce. Because if I have diabetes, I take medication for life, right? So I go for my clinics, my blood sugar is checked, if it's getting normal, dose is probably reduced, and then I continue, I have another appointment, you know, I keep going. So sometimes you can actually still be on those medications, and one day you go see your clinician and they check your blood sugar and they say, Madam, what happened? Your blood sugar is high. Oh, I'm so sorry, I went for a party and I took what I wasn't supposed to take. Okay, I'll adjust your medication and then we get back on track. So it's the same thing with mental illnesses. So if you have schizophrenia or depression, you're on medication for life. It manages the symptoms and you're able to live your life like every other person. So you keep going to see the doctors, they check you, adjust your medication.
So let me add to what that. So that man walking on the streets, like she said, has schizophrenia. And a subtype of schizophrenia called hebephrenic schizophrenia. And that man, hebephrenic. So there are different subtypes. There's paranoid schizophrenia, and there are different subtypes. So that man on the streets makes up about 1% of the entire population of people suffering from mental illnesses.
Many are mad, few are roaming.
It's a broad range of symptoms. From that woman who's not sleeping well, who goes to work and she's irritable. That woman who's lost interest in caring for her child. That woman or that man who wakes up every day and his mood is low. He's still going to work. And that's what they call presenteeism. So he's present at work, but he's not quite there. Right? So that's one part of the spectrum. To the other end of the spectrum, that man who is
now roaming the streets.
And like she was trying to compare. So it's like a heart problem and a brain problem. You can liken depression to like chest pain, and schizophrenia, which is at the other end of the spectrum, to like
heart disease,
like arrhythmia. So think about it. You see someone who has a fracture, who has a cast. You want to say, oh, you want to sign your name, get well soon. Everybody's so kind and loving. Then someone comes and says, oh, you know, I'm not able to do things any longer. I realize my mood is low, my energy levels are low. And you're like, look, snap out of it now. We're Nigerians, we don't get depressed. What's the matter with you? So with mental illnesses, you think the person is weak.
Yeah.
You think the person is in control.
Yeah.
But someone that has a fracture, you know it's not the person's fault, right?
Yeah.
And I think I want to talk about is the way we also present mental illnesses, which is the problem. Have you ever seen a comedian joking about cancer? Have you?
No. Well, no.
No. Comedian won't joke about cancer. But they'll laugh at that man roaming the streets.
Or people that stutter, things like
Or
that.
people that stutter. Or people that have learning disabilities.
Yeah.
You see those
Or
jokes, don't
cerebral
you see
palsy.
them?
Jokes about people that stutter are actually funny.
I've never laughed at it.
My dad was a huge stutterer, so I'm being cruel, right? I know. We have it in the family. I shouldn't be saying things like that. It's funny. We used to play tricks on him all the time.
Could you tell us a little bit about dementia? Because I hear about that, especially when speaking to some of my friends and when our parents are getting older now. And, you know, I've heard 1 or 2 cases where they tell me that, well, the doctor says, you know, dementia is set in. Could you tell us more about what dementia truly is?
Basically, it's a decline in cognitive functioning that mostly occurs in old age.
Okay.
And there are different subtypes of dementia too. There's the Alzheimer's type, there's vascular dementia, there's Lewy body, there's the different, but the main component is a decline in the person's cognition.
Yeah.
The person's higher functioning, judgment, memory, intelligence. So you see someone who was a George, who was very educated, and at 65, 70, he can't even feed himself, he can't even dress himself, he can't recognize his children. But it doesn't start as dementia. First of all, there's a cognitive decline. Now let me wear my lifestyle cap, lifestyle medicine. Because therefore, we can actually halt that decline. Because we notice these changes in our loved ones. You know, they can't find things, they're struggling with names. Of course, we may not forget their children's names immediately, and most times their long-term memory is intact. So they begin to forget what happened yesterday or in the morning. And lifestyle has taught us that you can actually hold that decline by exercise, doing things that, you know, that challenge the brain.
Stimulate your brain.
Stimulate the brain. But these days, we're not so much stimulating our brain that much.
That's right.
Especially people like us that always use Google Map.
Yeah.
So we've gone to a place 10 times. The 11th time, we're still using the Google Map.
That's right.
You know, so we can actually hold this decline. But it's very distressing seeing your loved one in that condition. Yes.
Barrister, you've been quiet.
Yes, you know, one man in my place, he said he doesn't understand English because he never went to any school. But that he knows that when people are speaking those volumes of English and he hears buts, he concludes that thing didn't go straight. So I'm not hearing all this dementia 1, dementia 2, but my mind is going somewhere as a lawyer. We know you defined mental health, and I picked from there. For me, law is an instrument for social control. In law, we say somebody is of unsound mind or he is intoxicated, is under the influence of drugs or alcohol for purposes of liability in crime. They say if at the time of doing the act he was of unsound mind or he was intoxicated. Now, what level of mental illness qualifies as unsoundness of mind to absolve somebody from liability? If they bring somebody who committed offense to you, say, check his head. So what level results to that unsoundness of mind for this purpose?
She talks about screening tools.
Yeah.
And
So
assessments.
normally, say for instance, we talk about let's talk about driving. The driving we know. So the road safety will catch someone and say, you know what? Because even when I drive sometimes, I actually think some people need psychological testing, the way they drive. I always say it's like we need to grab them, you know. So you take the person to the hospital. Now you don't just ask questions. So even when people come to us, you don't ask them questions out of the blues. There's a format to follow. And then remember I said that's why it's not counseling. There's a guide. So you're asking different kind of questions. You can ask questions ranging from How were you when you were growing up? How was the environment? How were your parents? So there are different questions. Now, at the end of that assessment, because that is our tool, the psychiatrist will use, their diagnoses and the pharmacology as their tool. Our tool is the assessments that we do on people. That's like our own injection.
Okay.
Because it's whatever assessment we'll do that will form what we call a treatment plan. So even if somebody comes, you have 5 people that come with depression, you don't give them the same treatment plan because everybody has different things that happen to them. So at the end of the assessment, that's when you now agree and say, okay, is there a problem? Or maybe you were just unruly and not, now we're talking about driving and not driving well. But if it's someone that comes and genuinely, they do have a mental illness, at the end of the assessment, you draw up a treatment plan for them. And you have sessions. You see them either twice a week, 3 times a week, depends on the severity of whatever illness they're suffering from. They also have follow-up sessions with the doctor as well. Now, Dr. Diaba was saying something about when you go to the hospital, someone that has hypertension or has diabetes, you have to follow up. In mental illness, for people to stay and remain in recovery, that follow-up is important. So you're taking medication, the medication finishes, you don't just assume I'm well. So even when you're well, you feel you're doing every other thing well, it's still important for you to have your follow-ups with your doctors. Sometimes they may want to reduce the medication if you're doing well. Sometimes they may want to go on a drug holiday if you've consistently done well. But for sometimes you have relapses where people abruptly will just stop taking their medication. Oh, I was gaining weight, or I didn't like the way the side effect it was giving me, and they have a relapse. Now, a relapse is when they go back to where they were before. Sometimes it's worse.
Sorry, I wanted to just...
Mental illnesses and bad behavior are not the same.
Good, exactly what I was saying.
They're not the same thing, though.
I want to rephrase the question. It's very important. It's of importance to me, having gotten this forum to discuss it.
Yeah.
I just told you that in law, they say if somebody does an act which constitutes an offense, and the issue of unsoundness of mind comes in, the trial will stop and they will refer the person for medical examination. It is the result of that medical examination that determines the next
action.
What kind of all these your mental illnesses that qualify as unsoundness of mind, as I see in our law books?
Yes, so it's
sorry, because you say we
say
should not mention madness. that will absorb somebody. Sorry, I'm coming. Let me give you a scenario. Udofia killed the father and the mother.
Good.
The case went to the High Court. He was convicted of murder and sentenced to death by hanging.
Okay.
The case went on appeal to the Court of Appeal. The Court of Appeal said yes, the High Court was correct. He should be hanged. The case got to Supreme Court. The panel of the Supreme Court sat. They said no. Normal people do not go about killing their fathers and mothers. That the 2 courts below should have inquired what happened.
What the state of mind is.
You understand? They went beyond. Yes, he killed somebody. Normal people do not go about killing their fathers and mothers. That's what Justice Oput of blessed memory asks.
Okay, this is a real...
So now, it's a real case.
Okay.
Now, that's why I'm asking. You say we shouldn't call it mad. What kind of your mental illness qualifies as unsoundness of mind?
Thank you, Barrister, because I was actually going to give you a scenario because that's the best way to understand it, right? Okay, so you have Udofia, like you mentioned.
Yes.
And when he comes to us, the mental, health practitioners, and in the course of actually assessing him, objective assessment, you find out that Udofia actually hears voices. Schizophrenia, one of the cardinal, symptoms is they actually hear voices that none of us, no other person around
How do you know
can hear.
I'm not pretending that I'm hearing voices.
Exactly. Good. That is the thing. It's unshakable. we call it delusions.
I see.
So we have ways of asking those questions. You can't convince them that they're not hearing those voices. And to make a diagnosis in mental health, you don't just hold on to one symptom. There's a diagnostic criteria with a diagnostic tool, either the ICD-10 from the World Health Organization or the DSM-5 from the American Psychological Association. So there's a tool. Yeah, so you have to fulfill a certain criteria of symptoms before you can label someone or before you can make a diagnosis. So you find out that Udofia actually hears voices, and those voices actually command him, and he believes those voices beyond anything. And those voices told him, if you don't kill this man and this woman, they're going to kill you the very next second. And he acted based on the voices. It's different from when you do an assessment and you find out that we do things like a personality assessment that the psychologists do, and you find out that he's antisocial. He's just a difficult, stubborn child. It's different from having a mental illness. With the mental illness where he hears voices, medication helps. Those voices might go away. In a lot of cases, at least they're able to manage them. So that's where what you do is you find out, okay, what he did, is it related to what you found out, as a clinician. In mental health, we don't have an ultrasound, we don't have an x-ray, we don't have a CT scan. It's called the soft medicine. It's our mouth. We explore the mind. So by the time you finish, what we actually find out, it's beyond, I'm shivering, I have a fever, I have a headache. You explore how was going on, like Maria said. You find out that some of them are addicted to things like sex or pornography. And you find out that this is someone that was exposed sexually from the age of 2. They were sexually abused. So if you don't explore, you just see him and you say, this is just a randy human being. It goes beyond that, right? So barrister, when we do that, our own is to give you a report and say, this is what we found. So there's a possibility that he acted on that based on, because you find them and it's a common feature. For symptoms, you don't eat the food cooked in the house because they believe they're going to be poisoned. Paranoid schizophrenia, like Dr. Rufus said, So they become suspicious, and sometimes they feel they're acting to protect themselves. There was a case in the US. The lady sat down, one after the other, and drowned her 5 children.
Yeah, I know that case.
Wow. One after the other. And the little kids, at a point, one of them was crying. He thought he was naughty. And he kept telling her, Mommy, I promise I'm going to be good. I promise I'm going to be good. She drowned them in the bathtub. After the last one, she picked up the phone and called 911. And they found out that she had actually told the husband 3 days before then that she thinks she's relapsing. Wow. He should take her to the ER. She knew. She was a known, patient with mental illness. And he took it for granted. He took her to the ER, they just gave her something for sleep, and they took it for... So at the end of the day, even the clinician was indicted. Wow. Because she came, and you know her history, and you just gave her something to help her sleep, and she went home. So in that kind of situation, imagine if you had the case, it's almost clear. Clear. It's just unfortunate that someone somewhere didn't do...
Anger is it a mental illness?
It's a mental health condition. Okay. Because we have people who manage for anger issues.
Yes. So
we have anger management sessions.
Yes.
I know you focus a lot on addiction as well. If someone is addicted to porn, for instance, is a person...
To porn?
Yes. Pornography.
When is it an addiction, for instance? There are people who might watch porn just for the heck of it. Can it be termed an addiction?
It is an addiction when it affects your normal functioning, affects your relationships with people, affects work and schooling. So you find out that you're staying away from work because you want to watch porn. Or you're avoiding your normal, maybe matrimonial duties because you prefer to watch porn or masturbate. Yeah. So it has to affect your activities of daily function. The people around you are worried about it.
How do you get people, especially for you as a psychologist, how do you get people through the door? Are people able to convince others that you need help, you need to go see a specialist? Is it because I can imagine the Nigerian mentality when you even come in, say, if you ask me to come and see, I'll give you attitude for the first couple of days because I'm like, what am I doing here? How hard is it?
Well, it's interesting because we get that a lot. We get that a lot. But sometimes, after a couple of days, especially for addiction. Let me use addiction. Mm-hmm. For mental illness, at the early stage, you don't really get that because they're unwell. Mm-hmm. So you can see the symptoms. So someone that's hearing voice, someone talking to themselves, you can see that someone irritable. But those that are addicted to the substance, for instance. So initially when they come involuntarily. They already tell you from the onset, I don't need help. I don't think I need to be here. Now gradually, because some of them come in and it's just pure addiction. Now there's another level. Some come in and they have psychosis, which is a mental illness and the addiction together.
Could you... The dual
diagnosis. So there's some people that have dual. Dual means they have a mental illness and they have an addiction problem.
Okay.
While there's some people that have drug-induced. So for instance, people using marijuana, for instance, might have a drug-induced psychosis. If you take marijuana away and take antipsychotic away, after a while, they should be fine. While you have the plain addicts, so people that are addicted to all sorts of drugs. So initially, it's a tough one for most of them. I'll say most of them, trying to settle in, because again, they have to stay in the center. They have to be there for 3 months. It's a total change of life for them. So it's a struggle initially, but as time goes, where they have their sessions, they see the doctors. We have something we call the MDT. So it's a multidisciplinary team. Okay. So it comprises of the doctors, the nurses, the psychologists, occupational therapists, social workers. It's a whole team that sits with this person and tries to assess their life, their drug use, what made them to start using drugs, their triggers, their cravings, their friends, their family, all of those things. You do that in those MDT sessions. You have family sessions with families as well. Because for some people, they'll tell you, oh, it's my mom, oh, it's my dad, oh, it's my uncle. So you have those family sessions as well to be able to speak to them and see how you can give the person support. Okay. Now, when it comes to addiction, some people come and say, I remember a father I saw some days ago. He said, can't you talk him out? Talk to him, tell him to stop taking these things now. Isn't that what you people do? But you don't talk someone out of addiction. Definition of addiction is a chronic brain relapsing disease. Chronic brain relapsing. So when someone comes and they say, you will cure my child, we say it's not cure, it's treatment. So that when your child leaves tomorrow and he's relapsing, you don't say, after all, I took you there. And that's what a lot of families battle with. So they end up taking them to different places because they feel, oh, this child is not yet cured. And we also have to psycho-educate families to understand what addiction in itself is. And that's why we have those family sessions. So yeah, sometimes you get people that are willing, they realize they need help, and they come for that help. Willing.
Yes.
While there are some people that even till they leave, they keep telling you that I don't think.
Even till the fourth admission.
They never agree.
I want to just address a bit something about mental illnesses, because we're guided strictly by diagnostic tools. We don't use, because a lot of people use mental health terms arbitrarily. I'm sad, oh, I'm depressed. Oh, I'm addicted to coke. Oh, I wash my hands too much. Oh, you have OCD.
Yeah.
So we don't, because it's serious. Before you say someone has a mental health disorder, certain criteria must be met. Yeah. We don't, like you said, we don't send people to the labs. We have to meet certain criteria. And about Udofia, there are a lot of things that can make Udofia kill his father. Auditory hallucinations, delusions of persecution, delusions of control. Sometimes they feel what I'm doing, I'm not the one doing it. It's also called passivity phenomenon, where they think someone else is, has taken over them and their bodies are being controlled by external factors. And unlike the GP, their consultations can be 15 to 30 minutes. But for us, because before you say someone has a mental health problem, you have to investigate. You must ask a lot of questions. So we follow this person from birth. We ask questions from birth until today. Everything about the person. Psychosocial history, psychosexual history, childhood history, family history, relationships. So we explore, because before Udofia killed his father, I'm sure they noticed behavioral changes in him. But because of the stigma, nobody did anything. And that's why we always talk about the stigma. Because if you don't address these problems, if you don't nip them in the bud, the consequences are grave. Look at this man that killed his father. I'm sure they noticed that he was a bit off. I'm sure they noticed that he was probably talking to self. Maybe he had stopped eating food in the house. He was being unduly suspicious. But maybe a neighbor said, this is Udofia. Something is wrong. Go. Take him to see a doctor. And they're like, oh, it's not our portion. And that's what we do. That's what we do in this environment.
That is what we
Before someone commits suicide, he's depressed. He's going on and on about the fact that,
I'm tired.
He's tired. He's lost interests. But nobody does anything. The stigma. And it's this stigma that has that's paralyzed us, that has affected access to help. And that's why things like that happen. And before you say someone has a disorder, first of all, certain criteria must be met too. Is this behavior different from the norm? Is it dysfunctional? Is it affecting his occupational functioning? Is it affecting his social functioning? Is it distressing to him? So, so I think we need to talk a lot about the stigma, because if we can nip these things in the bud,
more people will come out to talk.
People will come out to talk about it, and a lot of these dangers can be averted.
Some tribes, so sorry to vandal, but some tribes and cultures, before you get married into a family, they do background checks where they try and find out if there is a
history of mental illness.
Yes. So that brings me to the question. Is mental illness also a genetic thing?
Is it hereditary?
Is it hereditary? Can it be passed from one family to the other?
Okay, so it's interesting that our forefathers used to do that investigation, won't we say? So there's a reason they used to check, isn't it? So for them to have checked, if you find that you hear, oh, there's mental illness in their family, so my daughter isn't going to marry into that family. So there's a reason. So to answer your question, yes, there's a genetic component to mental illnesses. Causes, just like, I always like to refer to the physical illnesses because that's what people can relate with. Like with diabetes, you won't say, okay, just the fact that I take a lot of sugar means I'm going to come down with diabetes in future. So it's a multifactorial thing. Genetics, if I go see a doctor, he wants to find out if there's a history of diabetes in the family. Lifestyle, do I smoke? Do I take alcohol? My social environment, what sort of foods do I eat? So it's the same thing with mental illnesses. Biological, psychological, and social factors. So the biological factors, genetics. So if you have a parent or a sibling who has a mental illness, it increases your chances of having a mental illness. It's not an all unknown, yes. So it just increases your chances. Then now psychological issues. Oh, have I lost a loved one? Did I just lose a job? Did I lose a child? So psychological stressors, environment, again now social factors, marriage, divorce, so all these things come together to increase the chances or determine if someone is going to come down with a mental illness.
It's a complex interplay.
It's a complex, yes.
Interplay. So your genes are like a heavily loaded gun. What will pull the trigger? Your lifestyle.
Lifestyle. It's just like us talking about addiction as well.
So just sitting down.
So someone that, for instance, genetically they probably will be predisposed to having a mental illness, and they start abusing substance. So they have pulled to that trigger.
They have pulled the trigger.
Lifestyle.
And that's why two people use cannabis. This one is using cannabis and he's doing fine. He's doing fine. This one smokes cannabis once.
And he's on the street.
And he's on the street.
Something happens.
That genetic predisposition.
So the layman will say, oh, his head is not strong. That's right. So that's how they understand it. But it's the genetics.
Caged us from using the word madness.
Say mental illness.
I'm happy you are an Igbo person. I don't mind. I will speak it in Igbo and interpret it. In other words,
I know that word at least.
Yes. They say if you cure madness, you won't cure the murmuring and the occasional stop over to pick something on the road. So is it curable, totally curable, once it develops to that level of madness? You know, you people have not told me the one that qualifies as no, we have to call it
when it goes haywire and it's obvious that this person is not fine, especially the psychosis part.
And you know why I'm saying this? We attended a program. We were there for 1 year. They say it was typhoid. This guy got mad. I'm sorry to use that word. Left his hostel, ran to the road, entered town. They brought him. His roommates ran away. He stood in the whole place and was chasing women up, and everybody was scampering. This is somebody I grew up with. I'm just a year older than him.
Did he take something that day?
We were taken to the teaching hospital. Like these questions people ask, if you saw the embarrassing. I said, we grew up together. They say, what of the forefathers? They finished nothing. They took him to a prayer house. Well, now he is there, but like I said, if you are talking with him, you won't contribute. You will just be talking.
Is there medication?
No more medication now. He has a family. But I noticed the last time we traveled home, he's in Lagos. That's why I remember my people say, once you cure finish, you see him, this. I said, this guy is not well still. So I want to know
if it ever finishes.
Well, with schizophrenia, they talk about the rule of 1/3.
1/3, yeah.
The rule of
1/3.
Okay. So 1/3 of people will get well on medication.
Oh God, that's a very small.
1/3 will function on medication. So 1/3 will recover. Okay. Right? 1/3 will recover. Okay. 1/3 will function on medication. On medication. Another 1/3 will not make it. Will not make it. Will just
regardless of medication.
Can typhoid cause that madness? They say it was typhoid fever.
No, obviously they didn't know what was going on.
No, but there's something called typhoid psychosis.
Yes.
Okay, so.
You know, there's something called typhoid psychosis.
I've never heard of it.
He has not gotten back
the
to
way you have
himself.
perforated typhoid, you have hypertensive encephalopathy. Some people, severe hypertension, they start talking out of diabetic encephalopathy. You know, so a lot of things. So that's why in our assessment.
I was in the steering, my BP was 216. I passed out, came back, went to the pharmacy. They gave me a drug, my head was blowing. I got to my house, they said, sit down. I ran to the gate, went to the gate and sat there. They said, come inside. I said, I won't enter the house again. I went and slept in the hotel. My house I was afraid of going into my house.
So you see,
and this question has been on the tip of my tongue because this is another one that's almost always, it's like we don't even know it exists here because I only picked it up from watching a whole lot of Western content. Postnatal depression. I've heard women say that shortly after having their babies, they felt suicidal. They felt like killing the child. I'm not even talking of like in the context of out of wedlock where there's so much stigma, pressure and all that. Properly married women who are having their children in the most normal way, you know. Maybe sometimes even very natural birth that didn't come with any hassles per se. And a week or two later, the woman begins to develop feelings of animosity toward the baby. She wants to harm the baby. She wants to kill the baby. She wants to harm herself. She's thinking of harming the husband and so on. But I don't hear it discussed in our context here. It's like it never happens, or we're just pretending as usual that nobody has noticed, or we don't make the link between the fact that this woman just gave birth and she's now acting funny. Could it be as a result of postnatal depression? Is postnatal depression a reality here, or is it a Western construct?
It is a reality. And everything occurs along a spectrum.
Yeah. Yes.
So there's postnatal blues. There's postnatal depression. And so women have postnatal psychosis.
Yeah. Yes.
Okay.
So think about the hormonal. So like everything is a complex interplay, like we said. Think about the biology, the hormonal changes that happen in pregnancy. Then you bring a newborn. the stress of taking care of that child. Then your mother-in-law comes for a mugo, and you have to balance things out too. You know, so it does happen in our part of the world, and that's why we always talk about screening.
Yeah.
Because imagine if a woman comes for antenatal and you screen, maybe first trimester, you screen, you check, you ask all these questions. Second trimester, you ask all these questions. Third trimester, the same thing. And when she comes for the postnatal clinic, you do the same thing. Then you can identify it. Because sometimes...
Sorry, let me interrupt you. Yes. Are you saying that while going for
antenatal,
yeah, you should also be going for mental health checks?
You incorporate it in the antenatal.
Incorporated into
liaison.
So who should be doing it? The gynecologist or the pregnant woman will be seeing two different professionals?
You know, there's not necessarily. There's a way you can actually make it easy. Pregnancy is already not a very comfortable. It's already a stressful situation. So you don't want to send the pregnant woman to go see her obstetrician, send her to go see the mental health practitioner. So what, that's what we call liaison psychiatry. Okay. So psychiatrists will work with this obstetrics and gynecologists to say, okay, this is a simple screening tool. Say this simple question. So we keep it in the antenatal. We train them and say, okay, so 10 questions. So for every time your client comes, just help us ask these questions. So if you answer these questions, if you have up to 5 questions that they answer yes to, send them to us.
Did that happen to you?
So it's not all of us.
There's a hospital. I would say it's something we're even doing, because I know, was it last month? There was one hospital we're trying to liaise with. This one wasn't even for postnatal. It was for IVF, for instance. So people that come in for IVF, we had a screening tool where we had to draw out. We sat down together, the psychologists in the center, to bring it to map out a screening tool when people come for their IVF checkups, to give to them. Now again, people come for IVF, you don't even know why. So you want to ask them questions. What would have happened? Was it because they couldn't give birth naturally? You want to ask them, were you having troubles from your in-laws? How did that make you feel? How do you feel presently? All of those questions. Because sometimes some people might even be coming for IVF out of pressure. They're tired of being called maybe barren, like we say. Tired of the pressure coming from mother-in-law or from father-in-law or from sisters. So when you have that liaison with the hospital, and that's one of the things we're really propagating, that hospitals will be able to work not just independently on their own, but also with the mental health facilities, to be able to, when someone even walks in and say, I have a headache, there should be something that you can just do briefly and screen for other things, like a brief intervention tool. Okay, just brief questions. It won't take up to 10 minutes. After that happens, if that is ticked, and every staff should have a mental health first aid training. Yes. What are the signs I should look out for? If someone says, oh, I'm sad, you want to find out, because depression is, have you been sad for more than 2 weeks? Persistently. So when you say, I'm sad today, I'm sad tomorrow, no, persistently. Low energy or too much energy. You ask all of those questions. I'm not eating, or I'm eating too much. Just those basic questions can flag up something. Then you can refer and say, okay, I need to.
Red flag. We're actually out of time. It's a topic that needs like a part 2 and a part 3 and a part 4, honestly, because they're just, postpartum depression, postpartum
puerperal cycles.
It's a show in itself, to be really honest with you. You've been watching Conversations here on NTA Network. What are your thoughts on mental health, mental illness? Our social media handles are available on the screen. We would love to hear from you. So on behalf of all our experts, Devan and Barrister Ike, thank you so much, and see you again soon. Goodbye.